Good afternoon, ladies and gentlemen, and thank you very much for joining us in the latest in YouGov's COVID-19 webinar series. My name is Will Alstein, and I'm the Commercial Director at YouGov. I'm delighted to be joined today by two colleagues, Sarah P. Jones from Imperial College London, and Gavin Ellison, who is the Director of Public Services and Not-for-Profit at YouGov. We are taking a break from our regular program to bring you a special presentation this afternoon. And we're giving you very much a behind the scenes look at the data the scientists are using to fight the pandemic. I'll explain a little more about that as we go, and I'll also introduce my colleagues as we go through this. Let me just talk about what we're going to focus on this afternoon. So I am first of all going to take us through, just set the scene in terms of the work that YouGov is doing. I'm then going to pass over to Gavin, who's going to take us through the behavioural data that we're seeing, before we pass over to Sarah Jones to talk a little more about the science. And by the science, what we're talking about is we're going to dig in behind what R is, or the reproduction rate, look at the apparatus that brands and policymakers have in terms of creating ethical nudges. But let me set out YouGov's stance when it comes to COVID-19. Ever since the pandemic broke, our global CEO made a very clear statement to say that YouGov's priority and mission would be to serve the public good. And what does he mean by that? Well, he means that gives everybody the opportunity around the world to contribute to the discussion, to have their voice heard, and to aggregate that data in such a way that public health organizations and governments are able to use that aggregated data to really take the fight to this pandemic and affect a difference. But what we're going to focus on today is that behavioral data that we are supplying to public health organizations. And Gavin will talk a little bit more about that and actually take us through some of the highlights from that data. But just to be absolutely clear and create differentiation from the other types of data that YouGov is collecting, YouGov is also running a consumer monitor. This is designed for our clients and covers a broad spectrum of topics, including levels of concern, trust in organizations such as government, health services. It looks at changes in consumer habits, both now to changes in spend and media consumption, but also looking at future habits, those that have been learnt under lockdown and are likely to persist in the future. For example, a reduction in the use of cash. It also covers economic confidence, changes to employment, and how people have an outlook for the future. Elements of that data is brought to life as part of our public data offer, and that you can find on the YouGov website. But what we're here to talk about today is our behavioural data. This is what has been designed to assist public health organisations around the world, and is very much focused on symptoms, health-related behaviour, etc. So that is, but it's also, for the first time, YouGov has made this open source. So all of the data that Gavin is about to go through in this webinar is also available in its row-level form on GitHub. And in conjunction with Imperial College, we've also produced a dashboard at COVID Data Hub. Links to both of those I will put up at the end of this webinar, and you can also receive this deck after today, so that you don't have the need to scribble these down. But please do so if you wish. I've mentioned Imperial College London a number of times, and we have Sarah Jones on the call with us, and she will talk about the science. Let's just be clear about the YouGov partnership with Imperial College London, and in particular, the area that Sarah sits within is the Institute of Global Health Innovation. And when the pandemic broke, we put in a call to Imperial and said, how could we help? And what we came up with was a way to blend our complementary skills, YouGov's ability to poll, and Imperial College's understanding and of the science in this area to bring together community knowledge, attitude, and behavior studies, known as CAP studies, that helps policymakers and public health organizations understand the population and better develop strategies to affect change, and change that means the right people are doing the right things at the right time. So if that's just setting the scene, let me pass over to Gavin Ellison, who is our Director for Public Services and Not-for-Profit. Gavin.
Thank you, Will, and thank you for everyone who is tuning in. I'm going to take you through the data from the study that we have been running. So to set the scene, I'll explain what the study is. So we created a questionnaire in partnership with Imperial College, which covers a wide variety of subjects relating to COVID-19. They include the experience of symptoms, issues around isolating in response to those symptoms, a person's ability and willingness to self-isolate if it was necessary. We also have some questions in there which are numeric in their nature. So numerical questions which ask, for example, how many times you left the home on the previous day, how many times you're washing your hands, how many people you're coming into contact outside the home and inside the home. And these numerical data capture questions are really important for modelling purposes. There's also questions in there about what are people doing if they're working outside the home? Are you working remotely from inside the home? And a number of questions around preventative measures that you could take. So are you avoiding social gatherings? Are you using a face mask? And a number of things such as that. We've also more recently added questions around mental health using the PHQ-4 tool, which is widely used in many countries to assess levels of mental health. And we've added the Cantrell Life Satisfaction Ladder questions. One simple question which is used to measure that. We're able to offer to local public health organisations and academics, and in a few cases to WHO country teams, the ability to add questions into this study at a local level. So in a few countries we have extra questions that are running, which we're providing free of charge. We have just started to do a deep dive on everything related to masks and face coverings, a very sort of detailed section on that in terms of both behaviour, but also people's expectations and how they're finding wearing them, whether they have the ability to make them themselves and so on. And we have a small question section coming up on the issue of vaccinations, not just vaccinations for COVID-19, but whether people are actually missing important vaccinations, maybe children, for example, because they are worried about going into healthcare settings. The study that we created covers 29 countries globally, as indicated in this nice map. And it began in late March, and so from late March we've gathered around about now. Well, as a result today of a large upload, around 120,000 responses have been captured. The survey's been running weekly in 10 countries and every 2 weeks in another 19. and each response that has been gathered is date and time stamped, which is really important for academics and public health organisations who are using this to track behaviour, since you know the exact date in which a person completed the survey. And we have a number of standardised contextual pieces of information, demographic information such as age and gender, whether there's a child in the household, for example, and very importantly, whether the person has any pre-existing health conditions, which includes a list which includes things like diabetes or COPD, arthritis, asthma, those kind of conditions, which is very useful for policymakers to analyse the data by. So we have some data from specific questions to show you now. One of those questions is whether you would self-isolate if you started to develop symptoms of COVID-19. And we're showing a number of selected countries from the study on this slide here. Those in the US are sort of slightly less likely to state that they would go ahead and self-isolate if they develop symptoms than people in the UK, in Brazil and Mexico, for example. There is a bit of a gender split as well, so more women than men would say they would self-isolate, and that's the same in every country around the world. And there are really big differences on the basis of age groups as well. So just 64% of the 16 to 29-year-olds in the US say that they would do that. But it rises very steadily with age to a very high figure of 88% for those who are age 70 plus. There's a downward trend in almost every country that we're following in terms of people saying whether they would self-isolate if they developed symptoms. You can see, for example, the US, which is the purple line there, falling from a high at the beginning of the survey of 79% down to 68% now. And that's mirrored in most of the countries that we're following. You can see the similar sort of trend in the UK. And we wonder if that's to do with sort of increased confidence maybe in some of the other preventative measures that people can take, such as wearing face masks or coverings. Those who have got some pre-existing health conditions, though, it is useful to notice that they are more likely to self-isolate. So those who have got, say, high blood pressure, for example, high cholesterol, they have quite high percentage figures for saying that they would self-isolate. Whereas a person who has none of those health conditions that we listed out, so 68% of them said they would self-isolate. And a similar type of question, but this one is based on if they were to receive some advice from a health professional to self-isolate. So that basically in this case, it's not a decision that you're making for yourself, but it's one that you are being advised to do, perhaps having consulted a healthcare professional. And in this case, we're assessing a person's willingness to go into isolation if they were advised to do so. And there's this particular selection ranges from a high in the UK and Canada down to a lower figure in the USA. It's still very high at 84%, which is really that effect of being advised that this is what you should do. We have some interesting ways of looking at the data, though. In particular, if you cross this question with a question about whether the person is working outside the home. So those who are working in, say, food retailing, in logistics, or in education, in fact, are far less likely to feel that they would go ahead and self-isolate than those people who are working from home, which kind of reflects the fact that they're really sort of being driven to leave the home to work, and that's driving their reluctance to isolate themselves. You see some very stark figures there in terms of Canada, with a 97% of over 70s who are willing to self-isolate, compared to just 65% of those who are a younger age group. We're interested for a number of reasons in people's ability to self-isolate. So do they think that it would be easy or it would be difficult for them to do so in the future? This range has got an interesting range from a high in these selections in China and Canada, 75% saying they think it would be easy for them to do that if they needed to, down to much lower figures in Mexico and Brazil. And again, this is connected often to those who have a job which requires them to leave home, for example, that doesn't have that kind of flexibility. So quite a high figure of 37% of those who are working in the logistics sector in Brazil believe they would find it difficult to self-isolate. And there is a real difference between those who have got children and those who haven't. So, if you do have children, then you are more likely to think that it is difficult to do so. The willingness to self-isolate, if it's necessary, being advised to, is sort of slightly decreasing over time. So this chart shows the line shows the US willingness to self-isolate, falling from 86% at the end of March to 80% at the end of April. It's still relatively high, of course, and there's some similar figures plotted here in Canada and Mexico and Brazil, with the highest figures in Canada. We're able to cut the data in the US by the state in which the person is living, and this chart shows the top 5 and the states in which people are most willing to self-isolate if advised, and the top 5 who are least willing to do so. The ones who are most willing and would be most reactive are shown in purple, the likes of Indiana, Alabama, Carolinas, and Utah. As has been noted in many places, the aspect of wearing a face mask is changing rapidly over time in many areas. In the Far East, in the countries that we've been tracking, it was relatively high to begin with, although we did note in a couple of countries such as Singapore, it had risen from about say 60% up to 95%. Recently, you can see there in China it was around 90. It has been around 90 all the way through. In the US, the figure has risen really sharply there from a figure just over a quarter, now up to 75%. The figures in Brazil have gone from 49 to 90, and in Mexico from 54 to 88%, which is really sharply showing those changes over time. Say in the UK, we've not yet caught the bug, so to speak, for masks. Mask wearing is highest in the figures we have by state in California, in Colorado, New York, New Jersey, and Maryland, and is lowest in the states indicated in the color that I'd probably call turquoise, sort of a bluey green color. It's Minnesota, Wisconsin, Ohio, etc. They have quite an interesting question about avoidance behaviors, so avoiding small social gatherings. You can see the figures there in the US have shown quite a bit of change over time. So back at the end of March, 78% were avoiding small social gatherings. Nearly always or frequently they would be avoiding. That's dropped now to 70%. And in some of the other countries that we're covering, such as China, there's been a similar sort of similar kind of decrease there. Quite a sharp decrease in Germany from 82 down to a low there of 74, and then just up to 75 recently. In the UK, it's been very kind of solidly people avoiding those social gatherings. And this is obviously something that changes based on the policies that are in place in each country. We're interested in how often people are washing their hands because we're nosy like that. And we found in this selection of questions here, we have the highest levels of hand washing in Brazil. So on average, about 14 times on the previous day to the questionnaire being completed. It's exactly the same in the US, UK, Mexico, and Canada. So there's an average of 12 times. And the lowest one is in China with 5. And this chart shows the differences in the frequencies of hand washing. So in Canada, for example, you've got 8% who are reporting washing their hands more than 21 times in the previous day. And that's it from the survey behavioural data.
Fantastic. Thank you very much, Gavin. I think it's always fascinating to look at the that behavioural data, especially the international comparisons and things, for example, such as hand washing frequency there and the stark differences between where the behaviour in China as opposed to many of the other countries that we're looking at. Right, now on to the science part. We are delighted to have with us Sarah P. Jones from the Institute of Global Health Innovation at Imperial College London. She's a doctoral researcher in health behaviour under David Nabarro, who is one of 6 COVID-19 special envoys to the World Health Organization. But Sarah is not just a scientist or a researcher. She's also been in the driving seat behind a global brand. She used to be the global marketing director at De Beers, one of the LVMH brands. So she knows what she's talking about, both from the consumer perspective and how to drive a brand forward, but also understanding populations and how to nudge them ethically. I'm delighted to introduce her and she can sort of draw back some of the curtain on the science behind the pandemic. Sarah.
Thank you so much. On the screen, you will see where our data is available that we have been working on with YouGov. Imperial College London has been working very closely with YouGov offices in 29 countries since March to get data and insights into the hands of researchers around the world who are urgently in need of real-time data. It would be very difficult to imagine a more pressing time for data companies to offer data for the public good. And I know I speak for all the scientists and researchers involved in the Imperial College London YouGov collaboration and many more who are benefiting from the data when I say thank you very much for being so generous with the YouGov data around the world. On the screen, you'll see where the data researchers are using the data, and it's available for all of the public, including you on this call. The files are on GitHub, and they're also displayed in Tableau format on coviddatahub.com, which is run by Imperial College. If YouGov clients have questions about how to use this data being provided by YouGov to the Imperial College London team or the models behind what we're going to discuss today, please don't hesitate to contact them, info@yougov.com, and they'll put you in touch with me. There are 4 activities that we're working on together to support the research community, and we are providing policy and guidance to countries around the world with this. The first is coviddatahub.com. That's a publicly available dashboard. It's created by my department, and it's updated daily with the new data, including Johns Hopkins case and death data. We track trends over time in consumer health behavior related to COVID in 29 countries with the aim of developing very timely insight bulletins, which we share with our research network. We're collaborating with and informing other researchers, and I'm contacted every week by other researchers who are using the data for various scientific projects around the world, including people at Harvard, Oxford, Columbia, Edinburgh, the WHO, and the Bank of England. Our close collaboration network of researchers includes epidemiologists, public health experts here at Imperial, behavioral scientists and behavior risk planners at the leading public health organizations, economics collaborators such as Jeff Sachs and well-being expert John Hallowell, and the entire World Happiness Report team. One of the most important factors to consider when you are looking at behavioral data is the policy context in which consumers are operating. Researchers such as ourselves are gathering this important global policy data about how stringent restrictions are. This is from a source provided by Oxford University as a free service to the public. You can see here a visualization over time about restrictions on public gathering, which have taken over the world very quickly. This type of data is available in numeric format from Oxford University. It's also resident on our dashboard, coviddatahub.com. It's updated every single day for every single country. Now, why is this context so important for researchers, and why do you also need to track this data? In order to control unchecked virus transmission and virus reproduction rates, it is essential that the public performs the right kinds of public policy measures, such as those recommended by the WHO, at the right time. And when researching why and how health behaviors are occurring, it's important to consider the context in which they're happening. This helps researchers unpack the differences in behavior and attitudes. And one useful way of doing this is by comparing differences in behavior between countries operating under higher stringency policies at the moment and those with lower stringency policies. For example, among the higher stringency countries, 69% of respondents said they were avoiding going to shops always or frequently, versus 51% in lower stringency countries. We track this to understand more about how people's collective behavior is changing over time in relation to policy, with the hopes that researchers can understand better how this affects transmission rates. However, I bring this up here because these types of behaviors have clear implications for brick and mortar shopping. By tracking policy changes along with behavioral and local footfall data, you should have a better idea of when people will return to the main street for shopping. Now, we'll have our first deep dive on mask wearing behavior available in a week's time, but I would encourage you to come back to the Imperial College London YouGov COVIDdatahub.com or the GitHub page to download this data for 29 countries for free the week of 1st of June. At present, for example, we're looking at the differences between higher and lower stringency countries on wearing a mask in public. Higher stringency countries are wearing masks in public always or frequently 73% of the time, versus 49% for lower stringency countries. And this may have implications for virus transmission rates. An important consideration in life during and after COVID is life satisfaction. We will have much more to say about this in the coming weeks, but we will be announcing soon that the global leaders in this research are joining the Imperial College YouGov collaboration. That's the team behind the World Happiness Report, including John Hallowell, Jeff Sachs, Richard Layard, and Jan-Emmanuel Deneuve. The World Happiness Report is a report published annually in the spring by the UN Sustainable Development Solutions Network. Life satisfaction provides a very powerful umbrella measure of the quality of people's lives. In the annual World Happiness Reports, the differences among countries and over time in these evaluations are explained by good health, income, and 4 measures of the quality of social context: trust, generosity, having someone to count on, and freedom to make key life decisions. All of these elements are changing under COVID-19, often in ways never experienced before. The YouGov life satisfaction data collected regularly as the pandemic evolves in each survey country provide a very valuable barometer reading of life under COVID-19, reflecting each country's institutions and policies. Along with life satisfaction, good health, income, and quality of the social context, we're at the start of a long research dive on depression and anxiety around the world. Early figures indicate that there may be large differences in the global populations, with worryingly high levels of what we might call moderate and severe symptoms as measured by the PHQ-4, seen here in the week of April 27th. However, and we will have much more from this from our research collaborators in the coming months, there are worryingly high levels in Italy and Spain with around 1/3 of the population reporting high levels. Germany, as you can see, is quite low here, and the US is in the middle of the pack. But we would not be surprised to see this grow as economic damage widens. It's Mental Health Awareness Week here in the United Kingdom, and so I will take this opportunity to remind everyone on this call that there is no health without mental health. And if you are one of the many people who does not have a mental health program for awareness through your employer, you can contact me to recommend corporate programs or resources for you that are free of charge. And feel free to contact me about that through info@yougov.com. Now, why track behavioral data and not just attitudes? For those of you who are familiar with the now ubiquitous R number, this is going to make sense, but let me briefly explain the R number. First of all, it is an estimate, and that is very important to recognize. One easy way to think of R, or the reproduction rate, is the number of people a single person can expect to transmit the virus to. And if a region has an overall R rate of less than 1, then the virus is reproducing at a rate which will not grow exponentially in a population. However, if R rises above 1, then each person in the region where R is being measured is on average transmitting the virus to more than one person, and this is a rate which will grow exponentially in a population. The R number, unfortunately, has to be estimated retrospectively because of the time lag between infection symptoms and deaths. And at the bottom of this slide, you'll see the ways in which the R number has the chance to increase. It's these behaviors that we are tracking with the ICL YouGov health data set. So let's focus in on the lower right of this chart. This is crucial. Who is a case? Without widespread testing in the community, we cannot know who is a case or not. And most cases are probably asymptomatic, meaning without symptoms. It's essential that each country take responsibility to isolate each case and look after them and look after their household until all members of the household are healthy and clear of the virus. Their contacts need to be traced and notified. And it's at this stage, setting up this type of system, that many countries are in at the moment. Now let's move to exit strategy on the health side for a moment. There are 4 exit strategy principles from a recent World Health Organization communication: infection status, community acceptance, public health capacity, and health system spare capacity. Infection status, the first here is the rate of infection. This is the incidence rate, how many new cases, for example. The second is the doubling rate. Can you go to the next slide, please, Will? Thank you. The doubling rate is the number of days needed to double the number of infected people. The third is the case contacts. This relates to the R rates, where we want to see these at less than 1 per person. And testing positivity is less than 5%. Although this is very difficult to compare country by country, some countries are testing, for example, only healthcare workers, and some are testing fully in the community. Community engagement is the next principle, and this is very, very important. Without proper communication and engagement with citizens and local decision makers, the willingness of the public and of corporations and public services to comply with any of these measures is quite unlikely. The very unfortunate message that is also in this communication from the WHO is there may be consequences for companies and individuals as a result of the lack of coordinated preparedness that almost all countries have faced as a result of COVID. Increases in taxes and possible reductions in income and benefits may be inevitable. Now, moving on to health behavior. Are people complying with these directives, and will they continue to do so if the restrictions continue? This is a question on everyone's mind. There are many ways of attempting to answer this question and predict the answers, and one place to start is by looking at some of the evidence about what is known to drive people's health behaviors. The health belief model of health behavior pictured here suggests that key drivers of a positive health behavior, such as stay home, include a person's perception about the severity of COVID-19 illness, a person's perception of their susceptibility to the illness, what they perceive as the barriers and the benefits of staying home. Factors also include a person's general health motivation and the symptoms from their body or the cues from the environment that they receive about the illness. And that could be a dry cough. It could be public health campaigns such as Stay Home, Save Lives. It could even be other cues such as ambulance sirens or hearing people clap outside at 7 o'clock every night. But there is growing sentiment among those looking at the data that trust in health advice and trust in government are key to making actions stick, such as stay at home. Now, paramount to all of your businesses is the health and welfare of your employees as well as your customers. In the past, it's not likely that you were in need of forecasting while taking into account uncertainties that have not previously been relevant to the realm of brands. And Will, you can advance to the next slide. Thank you. Some of these constraints are out of your hands. Stores are shut, people are home or will be home soon. People are nervous, many are falling ill. To the extent that you are able to, you should include in your forecast models the positivity testing rate rising above 5%, the policy in your state, leaning on the governor's websites. And to forecast, keep an eye on the 4 principles I just mentioned, infection rate, doubling rate, case contacts, and the R rate. Now, I want to spend just a few minutes looking at models of how government and even brands can plan their actions around consumer behavior and attitude change. Here we're looking at the ethical ways to nudge consumer behavior. This is called the behavior change wheel. This is by renowned world leader in behavior change related to health, Susan Michie. On the outside in purple, you have the policy measures that surround people in their countries. These are fiscal measures such as stimulus packages, communications such as public health campaigns. It's very unusual for countries to use all of these policies in lockstep, but this is what has happened. The purple ring is the context in which all people are operating at the moment. And at the heart of these circles is the individual, and that's the green. We'll get to how you go from purple to green in a moment, but let's for a minute look at the green, the individual. Where does an individual's consumer behavior originate? Every individual's behavior starts with their perception of 3 things: their capability, their opportunity, and their motivation. An individual's capability is both psychological, for example, their perception of what they're capable of doing, and their physical capability of doing it. For example, are people physically able to get into a store to shop, or are they confined to their homes? If shops are open, for example, do they perceive that they can get in and out safely? Individuals' sense of opportunity is also driven by their sense of what they can manage physically and depends to a great extent on what they perceive as socially acceptable. Their motivation is driven by both unconscious thoughts, automatic reflexes, and thinking. For example, people withdrawing from those around them who sneeze. And in a happier setting, and this could be, walking by a Cinnabon counter in a mall and your stomach rumbling without your permission. Motivation is also governed by active thinking, such as, it's hot out today, I don't have a sun hat, I think I'll pop out to get one. And perhaps I want to use public transportation, but I don't have gloves or a mask, so perhaps I'll just stay home and reconsider my trip tomorrow. Now, it's actually in the orange and pink rings that both public health bodies and brands really need to think about. To shape the green part, the individual, the orange and pink rings are what are in your toolbox, and you can combine them in any way except coercion, which is not frequently ethical. For example, you can use persuasion to promote optimism, which influences capability, motivation, and opportunity. I'll skip over what the public health bodies are doing, and I'll give you my thoughts on how brands need to plan for economic recovery in terms of customers. For example, some brands may use incentivization in pink, such as discounting or launching new ranges to increase intentions in orange. And the idea, of course, here is to influence the green, the individuals, their capability, their motivation, or their opportunity. Many retailers will be using restructuring the environment in stores with tape for social distancing or different visual merchandising, and that's in the pink ring. To do the orange, which is to shape beliefs about consequences of shopping in person. Or perhaps you're offering curbside pickup with ordering via e-commerce. Both these ultimately have influence on the green, the individual's sense of capability, motivation, or opportunity. I would encourage all brands to lean on this model or models such as these to keep the fluctuations of government policy in mind when you plan your activities. Be prepared for what's coming next and for what that means for your physical presence. get the future plans from your retailers. Make sure your messaging is clearly targeting one or more of the green areas, and make sure you're clear about which methods and mechanisms of change you're using, and explore alternatives, both to maximize your impact and also for reputational risk mitigation. And again, if you have questions about this model, please don't hesitate to get in touch. And with that, Will, I'm going to hand it back to you.
Fantastic. Thank you very much, Sarah. That is a real privilege and fascinating to listen to you and get insight into the science and the models and finally get underneath actually what is R. We're now, we've come to the end of our elements of the content, but we are keen to hear from you. So there is a chat function on Zoom here. If you do have any questions for us, please do use that chat function now, and we'll try and get through as many of those questions as possible. I'll give you a minute or so to do that, but while you're doing that, I can talk about what's coming next from YouGov, what you can expect from our webinar series, and I'll also put up on screen the links to the data sources that we have referred to throughout this webinar. First of all, let me talk about follow-up. If we end this webinar and you immediately have a question or you want to understand anything about YouGov's approach, then please do get in contact with us. Our global email box is info@yougov.com. I will also, I promise to put up links to the data sources that we have talked about today. So for access to the data that Gavin ran through and that Sarah was referencing, you can download that at GitHub. It is github.com/YouGov data/COVID-19 tracker. That is the row level data that is available in, I believe it's CSV format. It's certainly compatible with Excel. There is also the Tableau data, dashboarded by Imperial. That is coviddatahub.com. And of course, for YouGov's public data, or to understand anything about our consumer monitor or our economic confidence tracking and recovery data, then please do look at yougov.co.uk/COVID-19. There is a similar US site as well, which is at the .com address. Right, I will open up the chat and see what questions we have in here. So please do keep them coming through. One question, I think this is probably going to Sarah or potentially Gavin. Just interested in the mental health elements, and could you give a bit more background as to what the measurement that we're using is and how widely that is used?
Yeah, I'd be happy to. The PHQ-4 is one of the most well-validated instruments in the world used to screen people for anxiety and depression. One of the reasons why it's so short, of course, is that many people don't like to answer long questionnaires about their mental health. It's been shown to have very good sensitivity and specificity, meaning it gets very good true positives and it doesn't come up with very many false negatives. It's used to measure 2 symptoms of depression and 2 symptoms of anxiety. And frequently it's used by researchers who are doing work in the field of mental health and medical problems. It's less frequently used, for example, in clinical practice, where longer screening items are more likely to be used, such as the GAD-7 or other more thorough. However, it has very, very high correlation with even longer versions, and that's one of the reasons why we're using it. Unusually, as far as I am aware, we will have the largest collection of PHQ-4 comparative data in the world that's ever been collected. And we're looking forward to getting into some of the explanations of why some of the countries are different, and also why the trends over time in each country are moving.
Fantastic. Thank you very much, Sarah. And just looking at those numbers, so we saw, for example, Germany, I think it was 16% of people that were reporting moderate or severe symptoms, up to some countries where we're talking about around a third of the population. Are those figures concerning to you, to policymakers at all?
They are extremely concerning, and I think that it's unusual to read the front page of any newspaper in the world today without a mention of the expectation that mental health is taking a huge hit in almost every country that has had lockdowns, large numbers of cases, and deaths. It's very unfortunate, not terribly surprising considering the burden on social contact that lockdowns have had, financial insecurities, and exasperating what could have been recovered people in the population as well. Anxiety has peaked before depression, is what we're seeing early on. Anxiety is the most common mental health problem in the world and is not recognized quite as well as depression because many people consider symptoms of anxiety to be normal stress. Which is not necessarily the case. And some very stressful life events have been happening to a lot of people, and we would probably expect depression and anxiety to increase over the next year and not decrease, sadly.
Thank you. Thank you very much, Sarah. Moving on. So there's one question that's come in on changes in consumer behavior, which I'll pick up on, and another one about sort of forward-looking. Gavin, you mentioned at the start of the webinar what was coming soon and a deep dive into face masks and something on vaccines. Let me answer the one about consumer behavior first, and if we can come to you then second to talk about sort of where we're going with that study. The first question was from Rob. Any comments on how consumer behavior may change in a spatially confined consumer environment? The short answer to that one, Rob, is yes, and I would encourage you, and we'll actually send you the webinar deck from that we've completed previously, looking specifically at consumer behavior. We have seen reduction in people sort of in gatherings, but actually it's more what I think you're trying to get at is more how are consumers responding? Are they more likely, for example, to make use of online delivery systems? Are they more likely to use click and collect services? Are we going to see people not attending restaurants, not using foreign travel? All of that data we actually are collecting in our consumer monitor and our economic recovery tracker. So what we'll do is we'll make a special point of sending you the deck from last time that I think will answer many of those questions. Gavin, just moving on to you to talk about developments of our behavioural data.
Yeah, so it might be interesting for you guys to hear what sorts of issues we're exploring as relation to face masks and coverings, which are really becoming a huge issue in the Western world, certainly, as we're kind of catching up with what's going on in Asia Pacific. So we're very interested in general sort of levels of willingness to wear a face mask or a face covering, and which types of organisations or which messaging would encourage people to do so. We're interested in the levels in which people are wearing a face mask, but also getting really into the detail, what types they are using. So the difference between the homemade ones or a medical one, people who are sort of adapting to using a scarf, for example, If they are purchasing either a medical type one or a cloth one, how easy have they found it to buy that? If they are using a home one, why is it that they've chosen to do that? Is it because of concerns about they might be taking supplies away from healthcare professionals who should be prioritised? Is it because of the issues around cost? Is that why they're kind of making one themselves? Do they also have the abilities and the skills to make one, in their home for themselves and for other people? We can't sort of just assume that everyone has got either the money necessarily or the ability to make a mask. We're interested if they are wearing them, what sort of experiences they're having, what sort of the barriers to do that. Is it making them feel weird, unusual? Is it a struggle to communicate? Do they feel sort of self-conscious around that? Are they also getting any kind of physical problems as a result of doing it? So is it making it more hard for them to breathe? Are they developing any kind of itchiness and discomfort? Those sorts of things which we need to consider how they might be overcome. There's also a slight concern about, well, if you start wearing a mask or a face covering, all of a sudden you start changing your behaviour around other things. So you might start sort of touching your face more often, you might not wash your hands so often, you might do other kind of things because it raises a sort of a veneer of protection, which is possibly not true. So yeah, we're very interested in all of those kind of issues and understanding the cultural differences between countries, and particularly those who have really embraced them and are using them very often, and those who have yet to do so.
Fantastic, Gavin. Thank you very much indeed. We're going to
add to that one.
Sorry, of course, Sarah.
Yeah, I just wanted to comment on consumer behavior and especially confined consumer environment, especially with retail. One of the things that I've been hearing from a big department store, Nordstrom, is how much care they're taking in planning for new retail environments in their stores, taking the advice of health professionals and mapping out very carefully how they will construct the store environment and hygiene and cleaning. I think that more stores need to be open to explaining how they are structuring their environment and measuring what people think about it. And that could include active surveys in stores to ask people how they're feeling. There is some early data showing that people feel better seeing people, an active cleaning force, for example, in a store. This, may be the case in restaurants. I haven't seen any data on restaurants for that, but I do think it's important that stores, brands, retailers share information on this because it's very costly for everyone when one store gets it wrong on a road, for example. If there's a main street, one store getting it really wrong can really decrease footfall for the whole street. So it's important, I think, in this environment to share that kind of information with each other.
Fantastic, thank you. Do you know what, it reminds me of a study that I worked on many years ago, looking at the London Underground system. And at that point, Transport for London were interested in perceptions of cleanliness. And the work that we did looking at not only how physically clean the stations were, but the biggest driver of public perception of cleanliness was the presence of cleaners, regardless of how clean or otherwise the station might have been. So I think it's a really interesting point looking at perception there. Perception obviously driving willingness to be in an environment, etc. Right, we're going to close up there. I don't think we've got any further questions coming in. So first of all, my thanks very much to Gavin and to Sarah for their insights today. But thank you very much our audience for attending today and giving up your precious time. A copy of these slides and the recording will be made available to you afterwards. And please do keep an ear out or watch your emails for the next in the series of the YouGov COVID-19 webinars. We'll be coming to you around our connected data, so looking at which audiences in particular have been impacted by COVID-19, and which brands are riding high and which brands have got it wrong. So it's a goodbye for us, and thank you very much.